parties come to the emergency department with a typical chest discomfort. ECG is non-diagnostic and troponin is slightly elevated. Now the questions becomes, what's the next move? Do we send this patient straight to the cath lab? Do we observe? Or is it safe to discharge the patient? This case captures the diagnostic uncertainty we often face in non-STE-based ACS, especially when symptoms are atypical and patients has comorbidities. And it's in these moments that biomarkers become critical, not just for diagnosis, but for stratification and planning for next steps. This image places non-STE-ACS in the broader ACS spectrum. Unlike STEMI, which is often quite easy to recognize with clear ST elevation, non-ST-elevation ACS can be very subtle, like normal or even non-specific ECGs and vague signals. And that's why high sensitivity troponins are so important. When troponin is not elevated, we may be dealing with unstable environment. But when troponin is elevated and there is a rise or fall, we may be looking at NSTE, even if the ECG is quiet. So the absence of ST elevation doesn't mean the patient is low risk. Troponin becomes not only a diagnostic marker, but a triage tool. So I would like to let us zoom out for a moment. Non-ST elevation makes up around 70% of all ACS cases. But here is the clinical dilemma. It's not a single disease. Some patients may have mild unstable angina, while others have significant myocardial injury. That's why the risk varies so widely. And this variability demands early and accurate risk stratification. We want to avoid over-treating low-risk patients, but more importantly, we cannot miss high-risk cases who need urgent revascularization. And to do that, we need to rely on clinical judgment, ECG, and critically, biomarkers. Today, high-sensitivity troponin have become central in that strategy, endorsed with a Class 1 recommendation by the ESC for early risk stratification. So let's take a closer look at which biomarkers matter and how they inform our clinical decision. Among all biomarkers, high-sensitivity troponin I and T remain the gold standard. They are essential not just confirming MI, but for risk stratification and timing of intervention. Both high-sensitivity troponin I and T are comparable in accuracy. What makes them powerful is that they support rapid rule-in and rule-out strategies, enabling safer and faster decisions. But interpretation is key. It's not about just crossing the 99% percentile, but we must look at timing of the sampling, magnitude of the delta change, and sex-specific threshold. So rather than asking, is troponin normal or abnormal, we must ask, what does the change mean in context? And to tell you the truth, I think the phrase of normal troponin is a bit incorrect. We should say non-elevated or elevated troponin. In practice, risk stratification starts with clinical exam, ECG, and serial high sensitivity troponin, ideally using the 0-1 or 0-2-hour algorithm. And let's break it down. If a patient has no ECG changes, no unwake symptoms, and normal serial troponins, especially with a validated algorithm, this is a low-risk patient, and we can often safely discharge them. The risk of MACE within the 30 days is less than 1%. But if the troponin elevated with dynamic change, or the patient has typical angina or ECG changes, this is a high-risk case, and we should go straight to early invasive strategy. But there are the groups that is in between, the intermediate group, where further testing is needed, either with stress imaging or coronary CT angiogram. This algorithmic approach is supported by both the ESC 2023 and HA 2025 guidelines and will help us personalize care without missing anyone. Now let's look at how common clinical decision pathways like HEART, EDAX, and ESC and GRACE helps us stratify chest pain patients. Despite different format, all of these clinical decision pathways rely on clinical features, ECG and troponin, particularly the high sensitivity assays. Some highlights for us to take. The HEART clinical pathway is practical and easy, so it's great for emergency department settings, while EDAX and EDA use stricter troponin rules for safety. EAC and GRACE are more detailed, suited for in-hospital decision and long-term prognosis. GRACE, in particular, has strong evidence and is widely used to guide invasive versus conservative strategy. So what's the take-home from this table? Use HART for rapid emergency triage, and we can use ESC and GRACE when planning the next step or estimating mortality, and across them, high sensitivity cardiac troponin is the foundation. Now, this is the ESC0102 algorithm. It's simple and powerful. We take a baseline troponin and repeat at 1 hour. If the levels of the troponin are low and stable, we can rule out the patient and discharge them safely. But if it's high or rising significantly, we can rule in the patient and proceed to the cath lab. And if we have a patient with the borderline troponin, we just observe and reassess. This method is validated and endorsed by guidelines and improves both safety and efficiency of the NSTE-ACS ACS management. Now let's talk about the most challenging group, the observed zone. Here, troponin is slightly elevated, vague symptom, and non-specific ECG. There are clear rule-in or rule-out cases, like the cases that I illustrated at the beginning of this presentation. Then what do we do with this type of cases? Then we should repeat measurement, look for delta changes, and evaluate the clinical context, either if the patient have any comorbidities such as sepsis, tachycardia, or whether it is an elderly patient. And we can consider adjunctive markers like NT-proBNP or copeptin to refine on risk assessment. So in this gray zone, we move from algorithm to interpretation. Now, when interpreting troponin, remember that not all elevations mean ischemia. We all have so familiar that sometimes we receive consult in ECG, then anyhow any patient just check troponin without any medical context. That can become very confusing. So these are the confounders for troponin examination. Age, older adults can have higher baseline values. Reflection, like a patient with CKD, their troponin levels rise even without ACS. Timing, early measurement when the patient just had an early chest pain and we measured the troponin at that distance. Sometimes early measurement may miss the rise, and sex differences, and actually have higher levels. So yes, confounder matter, but the pattern of change, the trajectory, even matters most. That is why serial testing of troponin is crucial. Now, let's explore what's beyond troponin. This table compares biomarkers used in non-ST elevation ACS. Aside from troponin that we have discussed, NT-proBNP is a key player for hemodynamic stress and prognosis, especially in dyspnea or borderline risk. And copeptin useful for early rule-out, especially when combined with troponin. The others are less common in daily use, but help refine prognosis and understand underlying information. The bottom line is that troponin tells us what happened, and the other helps us understand what's coming. In practice, two biomarkers stand out. High-sensitivity cardiac troponin is the diagnostic gold standard, endorsed by HA, BSc, and NICE. NT-proBNP widely used to assess heart failure risk, fluid status, and prognosis, especially in non-ST elevation ACS. The others are less preferred or still investigation. So, for your frontline tools, you can use confidently troponin and NT-proBNP. How do biomarkers integrate with risk scores? Initial triage start with, again, clinical history, ECG, and of course biomarkers like troponin, which determines your pathway using the 0-1 hour 0-2 algorithm. To estimate longer term mortality, you can use GRACE score, which includes troponin, but not NT-proBNP or high sensitivity cardiac troponin. This, however, can enhance predictive accuracy when used in combination. So increasingly, we're moving forward to multi-marker strategy, combining high sensitivity cardiac troponin with NT-proBNP to predict heart failure, in-hospital events, and post-discharge outcomes. So let me close with these three key points. First, high sensitivity cardiac troponin is non-negotiable. It remains the cornerstone for both 0102 our algorithm to guide decisions. And secondly, antiprobainability adds critical prognostic value, especially in patients with dyspnea and intermediate risk score. A level of antiprobainability above 1,000 should prompt postural monitoring or early intervention. And third, the future lies in multimodal stratification. Troponin for diagnosis, antiprobainability for prognosis, and race for clinical context. This gives us a more precise, individualized, and evidence-based approach to managing non-ST elevation ACS. And I would like to invite everyone to our conference in November.